Okay, this is Michael from Blue Sky Bio. I'd like to welcome everybody who's joining us for tonight's webinar presentation. As usual, if you have questions during the presentation, please enter them into the QA chat box and we'll address them during the presentation. Also, in addition, please enter your details into the webinar attendance form. The link to the form is under the video windows so that we could send you the CE credits. The CE credits will arrive via email, usually within around 1 week's time. For today's presentation, we have the opportunity and pleasure of hearing from Dr. Joe Ambrose. I'm sorry, from Mr. Joe Ambrose. He's the clinical director at Road Dental Lab. Joe's been involved in guided surgery way before probably I was. Anytime there's a difficult situation or a difficult question, tell the doctor, call up Ro, speak to Joe, he'll take care of it. He's probably seen more guided surgical cases than almost anybody out there. So today he's going to be presenting on the digital workflow of a fully guided bone reduction case with immediate provisional. Joe?
Thank you, Michael, and hello, everybody. Thank you for taking your evening to join us here for an hour. I think I have a pretty exciting topic to go over and present. We're going to talk about immediate provisional solutions for the immediate load fixed hybrid. And there's many ways to do this, yet we are embarking on a new way that some of you may be familiar with, others may not, to restore, to convert the immediate hybrid and make it easier, quicker, more predictable than what we're doing now, to the point where, you know, if any of you have had people come in to help you with conversions, this technique will make it so that you can possibly do it yourself, save money, and you know, really learn something that's going to help your practice. So we'll start out. The name of the system that that I'm going to show you, and I'll show you this last because I want to compare what we have done and what I do when I go out to do conversions with doctors and surgeons. I'll show you those techniques, and then I'll show you what we call the immediate smile system with using the guided pin protocol to restore these cases now. And you see a picture of it here, but you won't see the actual technique until later in the program. But this is pretty much what you know, what we get. This is milled. It's PMMA material. It's very strong. You know, very durable. Less breakage, and it's a nice thing to offer your patients. So what I'm going to try to do is compare the two techniques that we have used to the one that we are starting to use. One is the direct technique, one is the indirect. I will try to go through these things efficiently, so that we don't take you know, dwell too much on the older techniques, or the one that most people are doing now. So we'll start with the direct pickup procedure. You can do the direct pickup procedure. These cases don't have to be CT guided, or they can be CT guided. Most of the doctors I work with, frankly, don't use CT guides for the surgeons, that is, for their all-on-4 procedures. Yet that is beginning to change. It seems that when a doctor uses a guide for immediate placement for these cases, they're beginning to use guides. And some of the reasons for that are we make guides that allow us to reduce bone exactly where we need it to be reduced to create the space we need for the restoration. So that has been a critical problem. And I'm sure some of you have ran into that problem before, where the implants go in fine and you go to restore it and you don't have the space you need and you end up with a problem. So the guides and the bone reduction guides alleviate that issue. So with the direct technique, what we do and I'm sure you recognize this, is we'll take once the implants are in and the healing abutments are placed, or the abutment heads are placed, we take an impression and we find out where the implants are. Here's one here, here's one here, and we drill holes through the guide in the sites where we need to open up space for temporary cylinders. And what I'm doing here is just opening them larger so that when we get to the mouth with these, we have an easier time locating the cylinders through the holes. And one thing to remember about this is that everything that is done with both of these techniques, there's more steps involved. Up until the point of getting the implants in, everything's the same. But once you get the implants in and we begin to do the conversions on these, there's you know, some intraoral work that needs to be done, especially with the direct technique, that doesn't need to be done with the milled PMMA provisionals that I'm going to show you later. So, you know, the first step again was preparing the denture for the cylinders. We then put the cylinders in place on the implants, and obviously what we have to do is, once these implants are in place and the cylinders are in place, we have to check the bite. And that's pretty critical. With the direct technique, all these cylinders need to be cut down, ideally out of the mouth. So we have to get the denture fitted around the cylinders, mark where the cylinders need cut. Some doctors use a lot of water and cut them off with a carbide burr. Other doctors take them out and cut them off, but they need cut off either way, and it can become time consuming, and they need cut off and to the point where the patient can bite down into their centric and not have any interference with these. So this is what this would look like before they're cut. I think this is before they're cut. No, they are cut. They're cut down. So the patient can bite. And an important critical thing with this is that, and with all the techniques, even the newest one that I'm going to show you, that these cylinders must not touch any of the plastic that surrounds them, because it can change the way the denture fits in the mouth, and it can have a lot to do with how accurate the bite is. So we know that this denture fits in place properly, and we now put a rubber dam in place. And all this time, the patient's awake. They've you know, if they've been sedated, the anesthesiologist or the surgeon has brought them out of that to a degree where they can be coherent and help with the bite. So, you know, this is all going on at this point with them semi-awake or more fully awake. So they know what's going on, and they, you know, how some patients feel more pain than others, and you have to deal with that. So it's not, you know, it's not real clean. It's a little bit messy sometimes, but we get it done. But the rubber dam is placed over the cylinders, and the denture is placed in the mouth like you see here, and acrylic is injected into the holes. And once the acrylic is injected into the holes, the patient has to bite down into centric, whether it be in a pre-made bite or if the bite is very defined, they have to bite down into the opposing until that acrylic sets up. One point tip I'll give you here, I don't know what acrylics you use. If you use this technique, this material from Holmes Dental is very good. It sets up in less than 2 minutes, and you know, it's a good material intraorally. If you need an acrylic that sets quickly to pick parts up, attachments, anything like that in the mouth. I've been using it for a long time. If I have to do a direct pickup, this is what I use. Okay. So once the acrylic sets, this is what we see. And you can see we have some work to do. We have to fill these holes in. We have to make sure that the occlusion is as close to where we need it as possible. If the metal is still in the way, we have to grind that down. And so we at this point in time, we take the Teflon tape that has been put into the cylinders out, and we remove the denture. And this is what you see. Most of the time with this technique, you'll see that the acrylic has not flowed throughout the denture, and that we have to fill in. And most of the time, what I've seen with these things, some people use a light cured acrylic. I don't particularly care for it. I think it's or light cured composite. I think it's very brittle. I think it breaks easier than methyl methacrylate. But so that's why I use a methyl methacrylate with this. We have to fill in, and we're not always sure how much. So we fill in where we think that the intaglio surface is going to be, so that we try to fill in, not to overfill it and cause a seating problem. And at that point in time, we finish it down just like any other hybrid that we would deal with, and end up with this kind of a case. So all these hybrids, whether they be direct, indirect, or immediate smile cases, this is what they'll look like. I mean, the shape of the hybrid doesn't change. Okay, so one thing I'll mention too is that if you've done enough hybrids, you've had some of them break after they're in the patient's mouth, and that's pretty critical. If they break within the first 2 to 3 weeks, it's a critical time in integration, and you don't really know what to do. Afraid to take it out, you might disturb the integration process. So you end up trying to fix these intraorally, and sometimes it works well, sometimes it doesn't, and until this patient's implants have become stable, you're fighting a repair the whole time they're healing. And so this technique, this direct technique, causes us to use the least strong acrylic. These acrylics that set up by themselves, where you don't need pressure pots, don't tend to be as strong as those where you put under pressure to cure. So right from the start, we're using materials here that aren't quite as strong as materials we could use to help these survive the healing process. Any questions yet, Michael?
No, there's the question that came in that we were talking about slightly before the presentation started about the ideal cement to be using.
Okay. That question, I have to tell you that I don't get in. It's a resin cement. I'm not sure the brand that we use, but we use it in a syringe. And you know, again, it's a resin cement. But some of the tricks to this are, and I don't know if you're talking about PMMA provisionals or zirconia provisionals. There's the only two that would use a cement to hold the cylinders in. But we actually grit blast the cylinders, the part of the cylinder, not the inside, but the part of the cylinder that the acrylic's going to adhere to, and we put a primer on it, and then we cement it in place, and that seems to help. We also have cylinders come loose once in a while, and it's not enough to call it a problem. I think that once in a while you'll find this happening. So my best advice is to blast inside, roughen the surface inside that site, roughen the surface of the cylinder, and use resin cement to put it in place. And you know, I don't know what else I could say to help your problem, but that's what we do at the lab.
Okay. If there are additional questions, please enter them into the QA chat box.
Yeah, as soon as a question comes in, I'll stop and answer it. Okay. Just a little background. Michael said that I've been involved in this a long time, and I have. We've actually been doing guides, guided surgery guides, since 2004. I went to the initial rollout of the Nobel software It was the first program that they had ever put on for their planning software, and went. And not long after that, we got involved with it with Nobel and with another software that was available at the time, and we started doing guides. So in 2004, when we were doing this, and 2016, it's light years difference. We could not do bone supported guides back then. We could not do optical scans to scan models into position. The softwares were very limited in what they could do for us. So we could do tooth supported guides, but at that time, all we could do was make a copy of a scanning appliance. And sometimes the milling of the scanning appliances weren't as accurate as you think they might be. And we had to do a lot of adjustments on models to make sure they were seated properly. But now with optical scans, we make guides that fit the teeth very well, fit the bone very well. Tissue supported guides, that's a different animal. We don't necessarily, we do them, we have good success with them, but we also explain to the doctors that they introduce a level of inaccuracy, possibly, just because they sit on soft tissue, and you cannot control a lot of times on edentulous patients how they bite with that scanning appliance in their mouth, whether they're pressing too hard on one side or the other, or lifting the appliance, whether when they're put in the mouth, how they're held down in place, how they're fixated into position. All those things can affect the accuracy of a tissue-supported guide. And we used other softwares to make our bone guides until we had the ability with Blue Sky, and Michael worked with us a lot in trying to get that perfected, and now Blue Sky is the software we use to do it, and we have excellent success with bone supported guides. It's working very well. So I would have to say, technically speaking, academically speaking, that bone supported guides are more accurate than tissue supported guides. So that was a little caveat that I thought I should throw in there.
Okay.
Okay, so this is the direct technique, and it's harder on the patient, more work for the doctor, and it's harder to come up with an appliance at the end that is as strong as it could be or look as good as it could be. So the second technique that I use, is called an indirect pickup. And the reason I got into indirect pickups was because I wanted something that was easier for the doctor, easier for the patient, and easier for me. And so I worked on this and developed this, and this is how we do it. So once the implants are in, we take the denture that's going to be converted, and I hollow out a trough in the denture to the point where you can just about see through the acrylic, and put it in the mouth, and make sure that the denture does not hit impression posts, things that we're taking the impression with. We put short closed tray impression posts on the abutments and take a reline impression over top of them. And the patient can bite into their bite. The posts or the impression posts cannot hit the plastic when the denture or when the impression's taken, or obviously the bite's going to be a problem. But because of guided surgery, because we in Blue Sky, we can plan how much bone we're going to take off. We know that we're going to have 17 millimeters of space between the top of the implant and the incisal ledge or a central fossa. And when we have that, this technique never fails. So we take this impression. I'll trim the borders down until I expose plastic on the borders. cut out material exposing plastic inside on the intaglio surface like this. I'll put analogs in place, and all this pink, exposed pink that you see here acts like a reline jig, meaning that stone will set against it firmly, and when we pour the model, you'll see we pour a regular reline implant model like you would do for locators, actually, and end up with this. So this is what we're going to work on. Here's the impression posts. And we, at this point, put the temporary cylinders in place. So all the things we did in the mouth, in the direct technique, now we do on a model. So once we take this impression out of the mouth, here, with this impression in place, and put healing covers on the abutments, the patient can rest, they can sleep until we're ready to put it back in their mouth. And there's not very much intraoral time working with the patient. So the temporary cylinders are in place. I can then take the denture itself, put it in place. I know where the cylinders are, and I make holes through the denture to allow the cylinders to come through, just like we would do if we were doing it intraorally, but again, it's all done on a model. So you'll start to see here that this denture contacts the stone all the way around. And you'll see that if I had a view of the facial side, this flat surface that I carved on the borders touches the stone, and that's what preserves the bite, just like a reline jig would. And what we'll do with this is clean it up and inject material inside the trough that I carved before we took the impression, capturing these cylinders. So we've cut the cylinders down like you see here, and we're ready to inject acrylic. So I make injection ports around the denture. Clean it up with monomer. Previously, before I started, I made a putty matrix of the teeth and the palate. And what this was for, I do it a little differently now, but what this is for is when you inject your material through these holes, it prevents the acrylic from running all over the surface of the denture inside. So it makes it a little cleaner to work with once the denture is cured. I'll mix acrylic in a monoject syringe, fill the syringe, and inject acrylic throughout these injection holes that I made until I know that it's filled up. And put it in a pressure pot and cure it. We just use a simple portable pressure pot that this uses hydraulic pressure to create the pounds of pressure that's in the pot curing the acrylic. So right now already we're using better acrylic because we use the acrylic we would use on a normal reline, and we cure it under pressure, which makes the acrylic stronger. We don't have to guess how to fill up the inside or the intaglio surface around the parts, because we have a model to work to, and that gives us the exact position of the tissue surface, and the acrylic will cure right to it.
Okay, there are a couple of questions that came in.
Okay.
Isn't an impression post screw retained? Please elaborate on that part.
The impression post that I use, and I have special impression posts made for different systems. We make them on our milling machines. The impression post is a single part. It's a single piece that we simply thread down over the abutment head itself. It's finger tightened. On some systems, we have to use a screw that goes down through it. The key to it is that it's short. It's 5 millimeters tall. And another key to it is that the space that we create when we plan the case, that 17 millimeters of space that we've created allows these parts to be used. And we know that when we have that amount of space, that we're going to be able to take that reline without the parts interfering with hitting acrylic and preventing the denture from seating. So they're finger tightened abutment heads in most cases, and then once in a while we have to use a screw to tighten them down. But the biggest key is that they're short and they have geometry on them to allow it to place into the impression and know it's seated well. Okay.
Okay, the next question is bone-supported guide feasible for the maxilla, considering the lower bone density, making the volume rendering difficult, and raising enough flap to seat the guide would be difficult too?
Yes, we do make, frankly, we make, if I had to guess, we probably make more maxillary immediate hybrids than we do mandibular ones. So we do it. There is more tissue reflection on these cases. We try to make them as short as we can, but we can only make them as short as the amount of bone we need to reduce. So doctors sometimes have, first-time users, first couple of times they use them, it's kind of a shock. They're not used to flapping as much as they do with these things, but you never have to go clear into the vault of the palate to do it. They don't go down that far. They're designed to slip under the tissue because we put a bevel on the surface that towards the tissue, I guess you'd say, so it can slide under the reflected tissue, and it'll sit right on the bone. And you'll see here when I get to the part of the immediate smile how it works. But most of the people that use them like them very much, and again, it's because a lot depends on that guide and how much bone reduce to make the final restoration successful. Okay. The soft bone doesn't seem to be a major issue in the upper, and sometimes it has to do with the implant you use. I mean, most of these cases at this point are being used with, using implants with aggressive threads. I would say probably not 100% of the time, but in the high 90% of the time, the placing doctors are undersizing osteotomies so that they can compress bone when they screw the implants in and get the torque that is needed. I've been associated with over 300 of these chairside cases, and probably less than 10 the surgery or the conversion process had to be aborted because of soft bone. So it doesn't happen all that often. You'd think it would, but for the most part it doesn't. And if we plan it in software, the software can give you an idea of bone density. It does have Hounsfeld readings on it. They're not exact, but it gives you a feel for whether you're in low dense bone or high dense bone. So along with that and your surgical technique, you can, and the implant you use, you can actually help yourself be successful. What is the most aggressive thread, Michael, that you sell in the Blue Sky line?
Oh, I think the preference varies depending on the clinician. I don't know.
Would you have to say the Noble Active clone?
Yeah,
the
I'd probably say the Biomax is the most aggressive.
Mm-hmm. Because that's one of the keys to success with these, is the aggressive threaded implants. Okay, so The case is cured, and you can see that I'm removing the block out that was in the cylinders so that we don't have a fiasco of trying to get acrylic out of the cylinders. And once it's out, once they're clean, I simply take the screws out of it and remove it from the model. And you can see how nice the surface is inside. It's not a salt and peppered or injected looking surface. We have acrylic up against the ridge, just like it's supposed to be. And when we finish it, we can finish it however we need to, with within the parameters of where the teeth are and how much flange is on the case, to the point where we can make it high water or make a small footprint on the tissue to so that we can make it as hygienic as possible. But this is very good, hard, processed, heat cured acrylic here now that makes a stronger case. So one other thing that the 17 millimeters does, and this rule, 17 millimeters, is used no matter what, whether it's standard hybrids with a titanium frame, whether it's indenture teeth, whether it's pre-tau, all zirconia. And the space, and with pre-tau you can get away with less space. Academically, you can get away with less space, but what happens sometimes with less space is, you have to worry about a transition line, or the part of the mouth where the denture meets the gums. And if a patient smiles and shows that, the case is usually a failure. It's a patient acceptance failure, not a clinical failure, but they don't want to see that, and it's hard for them to accept it. So that's one of the worst problems you can have. So the 17 millimeter ruling is it's a good rule to go by. We have not yet been disappointed with that as far as transition lines are concerned. Okay, so, and again, we end up with nice hybrid finish. Okay.
A couple of questions. How often do you run into issues of the denture not seating due to possible distortion in the impression making or the cast pouring?
Is this the impression of the immediate denture when we make it, or the impression that we make at surgery? If it's if it's an impression problem from the impression we made the immediate denture on, basically what happens is you might have a bite issue. Now, we have been lucky. We have not had very many cases where the bite was horrible. We have had some cases where we did a little more adjustment than we needed. And we've had most cases where the bite just takes some minor adjustments to get it into position. We really don't have issues with the inaccurate model when we do these impressions chairside at surgery, because there's certain things you need to look at. We make a surgical bite that the patient can bite into, and that is made off of the articulated denture setup that we do in the laboratory, and it's indexed for, upper against lower, and when we put the impression material in the denture, put it in the mouth, the patient closes into that and preserves the bites that's on the articulator. So the only way that can be an issue is if the case was articulated wrong. So basically, if you have a situation where the impression's off with these kind of cases, because we have to grind so much of it away, usually we can bail ourselves out of it and adjust it until the teeth fit into the what we call the construction bite that's used to hold the patient in their centric, and really avoid a lot of problems. So that has not been a major issue with us. What is a major issue, and the worst issue, is trying to do these cases where you do an immediate denture, you send it in with a bite, and the patient doesn't have good centric stops. So on those cases, those immediate cases, I strongly suggest that you go through some try-ins to try to get that bite as accurate as possible before you finish the case, so that when we take it to surgery, the bite isn't an issue, because that can take a long time to resolve if the bite's, very far off. Okay.
Do you inject the material from only one point and watch for the excess coming out?
I put about 4 to 5 holes in it around the facial of the case, and I start on one end and I inject until I see a material coming out of the next hole, and I move up and move up and move up. And once I see it come out of all of them, I will let that acrylic set a little bit until, when I can try to inject it out of the syringe, that it's a little stiffer. And then I go back in and push more through it, so that, if there's any voids in there, the harder acrylic will tend to seal up the voids and make a better process case. If you do these enough, you're going to get a void once in a while, but it's never a problem where it's going to ruin anything. You just, you repair it, fix it, and finish the case. Okay.
Following up from a previous question that was asking about the bone density, how is the bone density controlled and defined well enough in the software to be a base for the guide in the maxilla cases?
How is it? Say that again.
How to control the threshold to make the bone defined enough as a base for the guide?
Well, the threshold can only be controlled in the 3D, and we don't measure any kind of Hounsfield units in 3D. We measure the Hounsfield units in the 2D screens, where we can see, we actually see cross sections of bone, and we can see the different variations in hard bone and soft bone. The whiter it is, the harder it should be. So we can determine by moving our mouse, and as you move your mouse over bone in the bottom right hand corner, you'll see Hounsfield reading units. And there's charts available online that will give you Hounsfield numbers and tell you whether it's D1, D2, D3, or D4 bone. So, and that's a good thing when we plan cases, to talk to doctors with and say, this bone's pretty soft. I mean, you must tell your patient that because of that situation, we may or may not be able to load this case because of soft bone. But I tell you, it's rare. Like I said, where we can, we typically get, I'd say the average torque we get is probably 40 to 50 Newton centimeters. Sometimes I've seen 70, 60's common, and 35 to 40 happens a lot. So the software will give you an indication of soft bone. It won't give you a definitive Hounsfield unit, but you get a sense for it just by the numbers that you see. Of course, the lower the number, the softer the bone. So anything under 300, that's pretty soft bone. So that's where the doctor needs to be aware that he may not be able to load it.
Okay, I think that's all for now. Okay.
All right, so now we are going to go to the system that we are now using. We just began to use it. I don't want to say it's in beta testing at this point, but not far out of it. We've had good success with it. The immediate smile system using CT generated guided surgery and the guided pin protocol. And I can't get in too much about how we do it, but you'll see on screen that it's very organized, very sequential, and very sophisticated. So it's more sophisticated generating one of these than it is using it in the mouth. So this is what it looks like. This is all the components of the immediate smile system. This purple is the bone reduction guide. The red is the osteotomy guide. The yellow is the PMMA prosthesis that is going to be milled and taken to the mouth and pinned into place and the parts picked up. Okay, so this is how we start. We plan the cases. We get the implants in position where they need to be. We locate the positions for the fixation screws, the pins, which is, you know, which is what makes this system work. There has to be fixation pins or it just doesn't work. And you can see this is an axial view of it. One thing you'll notice is the way we place pins. You know, we place them pretty deeply in the bone so that we get stability. You know, if you don't have stability, the guide, you have a hard time using the guide. You have to be able to put this in, put the pins in, and it's immovable. So we do something called transcortical pins position. We drill through the facial plate into the lingual plate so that when we put this pin in, there's no chance that you could rock it out of position. It's very stable. And you'll see down here on this bone model that there's one here. The gray ones are hard to see. There's one here, and there's one here. Okay. So once that guide is pinned into position, it's solid as a rock. And at that point in time, you know, we're ready to reduce bone. Now this shows the pins and the in place with teeth in place, but I'm going to go through this step by step. So again, this is the final solution, and here you can see that we have a way to mount these cases into centric in the articulator or in the software, and we make sure that in the software this bite is correct. All the sophisticated things that we do on this case comes down to how accurate the bite is. So whatever pains you have to take to get a good bite for us, that pays off in in many ways, and especially when you can do a case and the patient bites down and you have 3 or 4 minor adjustments to do, and that's all. So the bite is still one of the major components of this technique. So here's our starting point. You can see the pins in position between the implants. I showed you this picture a little earlier. You know, pin here, pin here, pin here. But what I'm going to show you here are initial abutment angles. These cases require the use of multi-unit abutments, which are abutments that come in straight 15 or 17 degree angles and 30-degree angles. And we have to choose abutments that allow the prosthetic screw position to not come through the facials of the teeth. We try to keep, in the anterior especially, we try to keep the screw access holes lingual to the incisal edge of the teeth and somewhere around the cingulum area, so that when it's all said and done, you don't have to repair holes in teeth because a screw access hole is there. And you can't do that totally successfully unless you do it with guided surgery. This technique, the immediate smile, must be done with guided surgery. There's no other way to do it, because you cannot accurately plan by hand and make a denture that has holes where they're supposed to be and has a way to pick up the parts in that prosthesis in a very simple fashion. So this is the designed and pinned bone reduction guide. Here you see it on the bone without the teeth extracted, and here you see it on the model without the teeth extracted. But what you do see is that the level of this reduction, this shelf right here, is even with the top of the implants. So where you reduce bone, is should be even. I'm sorry. Where you reduce bone to should be where the top of the implant should end up after it's placed into the osteotomy. So that shelf you create in the bone is where the top of the implant should be. So this is what the guide would look like in the mouth, placed on reflected bone. And now you can see how much bone you have to remove. And first-time users get a little nervous about that. But one of my other strong feelings is that if you want to do this appliance and you can't create the space, then I suggest going to Crown and Bridge where you don't need as much space, because if you make one of these appliances without the proper space, it'll deteriorate. It'll fall apart over time. It'll break, and it'll be pretty much a nightmare for you. So following the rules equals success with this technique. So this is what the guide would look like in the mouth after the bone's reduced. You can see these straps that are on here that would rest on bone. Now you just see the space where the bone was taken out. Okay. Now you see the osteotomy guide, the red, and I made this a little transparent because here's the bone shelf. And this osteotomy guide should be able to be placed on the bone and the pins placed into the same holes where the bone reduction guide was. If when you place this guide in the mouth and you cannot use the same holes, that means that somewhere you didn't relieve enough bone and you have to go in and find where that is and relieve it more until you can seat this and use the same guide pin holes. Another key is that when we do these, the teeth that you see here now are denture teeth. We do a setup, and we have a way of importing this setup into the software, mounted against the opposing model into occlusion. And we then take that and now we can compare it. You see where the incisal ledges were on the teeth that were there, these white. We now can compare the difference in position of the teeth from the original teeth to the replacement teeth. And this isn't too different. Quite often people have very flared teeth. The patient wants the teeth brought back. And if we plan a case on the position of the original teeth and make a denture with the teeth brought lingually, we run into a situation where we're going to have problems with abutment head angles, and we might not be able to overcome them enough to keep a screw head lingual to the incisal edges. So superimposing the final setup and arrangement of teeth and finalizing your implant positions accordingly is one of the critical steps. So here you've seen that we know this is where the teeth are going to end up, and we've made sure that these yellow posts represent where the screws will come out. The screw holes will come out so that you can screw this into the implants. Now, angulated abutments were used here. The two terminal ones are 30s. I think the rest of these are 17s. And we have to use those to give us the flexibility to create screw emergence position where they need to be. This is the final pinned PMMA that we made from the setup. We take that image, we take it to our milling machine, we feed the information into it, and it mills out this PMMA denture, hybrid denture, according to the setup that we've had. And it gets pinned to the bone. And this is where we begin the process of picking up the parts and doing the conversion. And this is what this is the key to it. We make the holes in the linguals of these dentures according to the abutment angles that we've used, so that when you go to the mouth and you put the temporary cylinders in place, they emerge somewhere in these holes. Now, sometimes you might have to do wee little adjustments, but it shouldn't take a lot to take care of getting these things in place so that, so that, you know, everything is accurate and there. So everything is accurate and you can pick these up directly. Direct pickup, you can't go wrong. It's in the mouth, so you should be able to pick these up, finish this denture down, and put it in the mouth. And one of the nice things about it, it's made like the hybrid. So there's not a lot of work left once you get to this point and take it out to finish it down and put it in the patient's mouth. Okay, we make sure that this PMMA then occludes with the opposing, which it does. I mean, we can do this all in software and it works. Once we set a bite, it can't go wrong in the software, no matter what. So this is not the setup anymore that you see. This is the final milled provisional, and the design of it that's going to be milled out in our milling machines. So that's really this is our software protocol. This is all done in Blue Sky. And this is what we send to our printers to make. So now I'll go through the surgical protocol. You know, we've made all this, we've sent it to the doctor. He has all the guides he needs, and we start. So this doctor, these slides that you see are courtesy of Dr. Era Nazarian in Troy, Michigan. We're working with him on this technique to work out any bugs that might be with it and make this the best product we can make. But at this point, you see the guide seated with the pins. He's now leveling the bone even with this surface of the guide, and this surface represents how much bone we need taken down to satisfy the space requirement we need. So at this point, he's just reducing bone to where we need it. So the bone has been reduced. The osteotomy guide has been placed, and you can see the pins in place here. These pins are in the same holes that were used for the bone reduction guide. So what that means is that because these are in the same holes, when we drill these implant depths, we know they're going to be accurate to the depth that was planned in the software. So this is what we end up with. So once the bone has been reduced, this PMMA is pinned into position. And again, repeatable bone holes. We put these pins back into the same holes that were used for the reduction guide and the osteotomy guide. And this is where we do the pickup of the parts. So wherever you see these holes and these yellow posts, one of these temporary cylinders that you see here will be in these holes. So at this point, once the cylinders are in place, the holes are good. None of the cylinders touch any of the plastic. You can take and inject acrylic into these holes around these cylinders, let that set up, and once it's hard, you can unscrew it, take it out, and finish it down. Now, while this process is being done, while we're finishing down the hybrid, the surgeon is then, if somebody's there helping him, the surgeon doing suturing, and whoever's doing the conversion is in the lab trimming this up into its final shape, ready to insert. So this is the case after suturing, after filling the holes, finishing the denture down. This is it in the patient's mouth. And this is the result for that case. So, big difference. And this is another case we did together. Same situation. And here's the chairside result we got that day. So that's the end. If anybody has any further questions, I'm happy to entertain them.
Yeah, there's a question that came in. I think the question is why to use a bone reduction guide. You could use a guided surgical guide to place the implants and then reduce the bone to the level of the implants. The accuracy of the planning ensures vertical implant location to be used as bone reduction guide.
You can do that, but remember that let me back up. Remember that this whole thing is coordinated for all of these parts to fit together. The bone reduction guide is made to reduce the correct amount of bone. The osteotomy guide is made to fit over that to do the osteotomies. And the PMMA provisional that you see here is made to fit in place using the same screw holes. These screw holes make sure that the bite is correct, make sure that the bone reduction is correct, and allows you to pick these parts up directly. If you put implants in and lower the bone down to the implants, this part here, these pin parts haven't been used to do that with. So, I mean, we don't do that. I would have to think about that some to see if that's a possibility. Some doctors do that, but most of the time when they do it, they use one of the conversion techniques that I showed earlier, either the direct or the indirect. So this should really save quite a bit of time for you and be, extremely accurate and, a very successful prosthesis. This PMMA material is much stronger than methyl methacrylate acrylics or light cured composite materials that you might use to make the conversion dentures. So I think that this technique is superior in many ways, and it's only going to get better. Everybody's going to continue to improve on what we have now, and the idea is that instead of having and we're a lab, so I mean we go out and do these things, and it's a service we offer for money. We charge, and these cases will stop us from going to dental offices to do, but we think it's the right thing to do. It makes it easy. A good staff person with good hands and some knowledge can learn how to do the conversions for you, and you keep some of that conversion money in house. So we think it's the future. We think that it's going to go forward rather than backward, and going to get better than it is now. Okay. Anything else?
Yeah. Is there a new tool in Blue Sky plan for making the bone reduction guide? How do you make a bone reduction guide? Go ahead.
We can make guides. We do everything in Blue Sky. We have to use a second software just to design the guide on the bone. But everything starts with Blue Sky and ends with Blue Sky. But I think that you're working on that though right now, right, Mike?
Yeah, that's been something that's been in our pipeline for a while, but there always seems to be something that's a little bit more urgent, something that people are waiting for a little bit more. We released a new build of the software around a week or two ago that includes a lot of new functionality inside of it, but this is something that wasn't yet included, but it's still on our roadmap and our pipeline, and it is something that we plan on addressing.
Well, you know, let me go back one couple. I
There
have
is a
to tell you,
technique to do it in the software, but it's not as streamlined as it could be. There is a way to design the bone reduction guide in the software and the implant placement guide, of course, in the software, and it could be done, but they're just it's a process and a bunch of steps involved.
right. What you see here, these angulated abutments that you see right here, in order to get these angles to be able to put a cylinder on and end up in this hole, when you place your implants, you have to stop the implant at the correct position so that the internal hex of that implant allows this abutment, the angulated abutment, to come lingually or facially, if that's the way you have it designed, so that it lines up in this hole. On your torque drivers, Michael, do you have a stopping point or a place where you want the facial of the implant to be or a lobe of the implant to be so that can be made possible?
Oh, Dr. Lerner just posted a bunch of information on this, I think, on Dental Town and on Facebook, but he's really the expert, and I'm not going to be commenting on that. You could check the posts or you could contact us, but he really provided a good explanation of how that works with the drill system.
Yeah. If when you try to put a cylinder in place, if the thread timing or the hex position of the implant isn't exactly where it should be, one of these posts might end up angled a different way. So you might end up saying, oh, I got to relieve this area here more. Well, in fact, the simplest thing to do is go in, take the abutment off, turn the implant a little bit until this cylinder ends up right where it's supposed to be and where it was designed for success. So if you start doing these, you'll get used to that. And if you talk with your implant company or look up these things that Sheldon Lerner just wrote, or call, they can help you make it easier on yourself to allow these angulated abutments and temporary cylinders to end up where they're supposed to be, to do this technique and have them end up in these holes so that they're filled easily.
Okay, another question that just came in. What success are you guys having with guided surgical guides and pre-made full arch PMMA provisionals? The titanium inserts for the pre-made provisionals is what comes uncemented. We have had great success with flapless surgery and pre-made provisionals. The cylinders coming out of the PMMAs has nothing to do with surgery. That's just a mechanical procedure that you use to cement cases in. So you have to make sure that the technique you use to put the cylinders in the PMMA, you're following a protocol of sandblasting the outside of that cylinder, make sure there's a little bit of a roughened surface inside the plastic of the PMMA, put your resin cement around it and seat it and screw it down and let it set. If you try to do these on very smooth silver metal pieces, you're setting yourself up a little bit for things that happen like that. But I will tell you that if you do enough of them, you might have one of these come out. But if you're having a lot of them come out, it's technique. It's how you're putting them in and securing them in place. So you need to look at what you're doing as far as preparing the cylinders for the resin cement, and make sure your curing times are correct, that you're following manufacturer's instructions on how to do it. Okay, go ahead.
Yeah, we don't have a big issue with that. Once in a while, one comes back like that, but for as many as we do, we don't consider it something that we need to change. We just have to make sure that we do it properly when we do it. Okay.
Okay, I think that pretty much wraps up the time that we have and the presentation for tonight. Everybody should enter their details into the webinar attendance form. It's in the comments section underneath the video presentation. And for more information, of course, you can contact Road Dental Lab. They're a great resource for your cases, for surgical guide planning, for all your lab needs. And Joe has the contact information on the screen. And if you have any questions regarding the software or Blue Sky Bio product, you could contact us at plan@blueskybio.com or via the phone numbers on our website. Joe, I'd like to thank you very much for the presentation today.
Oh, you're welcome. It's my pleasure as always.
And I'd like to thank everybody for attending. Have a very good evening.